Pari, what time usually they start the program?
So starts between 9 to 9:05. We can start.
Okay, okay. So I think we can wait for 2-3 minutes then. I don't know.
Yes, sir.
Yeah, we start. Yeah.
Good evening, everyone. Today we'll be discussing the journal club presentation. So the article that I'll be discussing is the effects of delayed versus immediate umbilical cord clamping in reducing death or major disability at 2 years corrected age among very preterm infants, which was the APTS trial and was published recently in Lancet. So firstly, just coming to the background of the cord clamping and various methods. So initially, the practice of delayed cord clamping came, then the controversy arose between immediate and delayed cord clamping several years ago, almost 30-40 years ago. Then came the concept of what is early cord clamping, which is clamping within 10 to 15 seconds. And for delayed cord clamping, the recommended durations vary from between 30 to 60 seconds to 3 minutes. And the basis for this being, which was done and found out over several studies, was that the method of delayed cord clamping, it did not cause a sudden interruption in the blood that was flowing across placenta, thus improving the superior vena cava flow and thus improving the cerebral oxygenation in these patients, because the sudden disruption of the cerebral blood flow does not happen. So thereby causing better circulatory stability and thereby reduced requirement for even inotropes in preterm babies in the first few days, also giving a lower risk for necrotizing enterocolitis, IVH and sepsis. And it was also found that there was a decreased need for mechanical ventilation and surfactant at birth. In terms of late benefits, it was found out that it improves hematological status, and also there was a benefit to neurodevelopmental outcomes, for which very large trials had not been conducted as yet. However, in several small studies, the white matter changes were evident, meaning thereby that it could cause a benefit in the neurodevelopmental outcomes if these babies were followed up at a later age. So this is the first, like, how the study was postulated. So the original APTS trial was actually done in 2000. The recruitment started in 2007. So until then, there were these 11 RCTs that were referred upon, and the summation of all of that resulted in an analysis saying that what I have highlighted in the box, saying that the in terms of intraventricular hemorrhage, NEC, and late onset sepsis, there was a significant reduction in the risk of all of these in preterm infants. And in terms of mortality also, there was a reduction. However, this was not found to be statistically significant. However, the more recent data which has been done, these 3 systematic reviews that were recently done. The one was done in 2018, which looked upon the delayed versus umbilical cord clamping for preterm infants, which found out that with a high grade of evidence, there was reduced hospital mortality. Also, this one of the major, the Cochrane reviews, which is the most recent one that was published in 2019. This was done, which showed that delayed rather than early clamping may reduce the risk of death before discharge for babies born preterm. However, to comment upon the duration of this delay and the exact timing, there was insufficient evidence. And the most recent one, which was published in Pediatrics in 2021, said that delayed cord clamping was associated with some benefits for infants less than 34 weeks. There was no such evidence, significant evidence to comment upon the umbilical cord milking method, and it said that the early clamping may in fact be harmful. So just giving the basis and before we go on to the actual the APTS follow-up study, I'll just give a brief overview of what the original study was about, which was published in 2017 in NEJM. They aimed to establish whether placental transfusion in terms of delayed clamping in babies who were less than 30 weeks gestation will have improved health outcomes in terms of death or major morbidity as a composite score and individual as well. So they included the babies less than 30 weeks gestation. The intervention arm was delayed cord clamping with early cord clamping within 10 seconds as a control arm. The outcome they looked upon was composite of death or major morbidity as a primary outcome, where morbidity being brain injury, chronic lung disease, severe retinopathy, NEC, and late onset sepsis at 36 weeks post-menstrual age. The study was conducted over a period between 2009 to 2017. And what they found out and gave as a concluding statement was that no statistical significant difference in the primary outcome of death or major morbidity was seen at 36 weeks post-menstrual age. So what they said was that when both the groups were compared, there was a 6.4 and 9% mortality, and there was actually a relative risk reduction in mortality of 31%. However, when they adjusted this for the multiple secondary outcomes, the effect was not statistically significant. So the aim of this study is to compare the effects of delayed clamping versus immediate clamping on death or major disability at 2 years corrected age, which were these same babies who were followed up at a later age. So this was an open label, parallel, pragmatic, randomized controlled superiority trial, which was done across 25 centers, which included 6 high income countries in Australia, New Zealand, Canada, US, UK, and Europe, and one low income country, which was Pakistan. And the follow-up study was conducted over a period of 2015 until 2020. They included babies who were less than 30 weeks of gestational age. The exclusion criteria included fetal hemolytic disease, hydrops fetalis, twin transfusion syndrome, genetic syndromes, potentially lethal malformations. To note is that for a non-vigorous infant, the clamping was done at clinician's discretion. Hence, the babies who had a lower muscle tone or who did not have good spontaneous breathing, did not cry at birth, all of those babies were actually not excluded from the study. They were still randomized into either of the two arms. So randomization was done using this interactive voice response method, which was 1:1 randomization using an automated telephone service. The parents and care providers could not be blinded. However, assessment of disability status later was done by a blinded assessor. Assessment was done using a short health status questionnaire, and a parent completed ages stages questionnaire 3. And in case of an inconclusive result, the Bailey scales of infant and toddler development were referred to. The major primary outcome was death or major disability at 2 years corrected age, where major disability meant either of the 5, which was cerebral palsy and unable to walk unassisted at or after 2 years of corrected age, severe visual loss, which was defined as legally blind or having corrected acuity less than 6/60 in both eyes, deafness requiring a hearing aid or cochlear implant, major language or speech problem in terms of inability to use more than 10 words, including the signed words, and cognitive delay, which was defined as ASQ score more than 2 standard deviations below the mean score for the problem solving domain per se. The secondary outcomes were incidence of death and major disability at 2 years corrected age, the 5 component scores of major disability which were there in the primary outcome, and all 5 ASQ3 domain scores. So coming to the statistical analysis, this was an intention to treat analysis, and why that was relevant, which I'll be talking about subsequently. And treatment effects were expressed as relative risks and in terms of 95% confidence intervals. Sensitivity analysis of each of these of the primary outcome was adjusted for each of these variables for gestational age, sex, birth weight, multiple birth status, and mode of delivery. The effect of missing data on the primary outcome was assessed by multiple imputation with chained equations. So what is multiple equation? I'll just briefly tell is that if you're doing a study, that study may have some missing data, or that study, so to deal with that missing data, either you just hide that missing data or you just feign or forge for a missing data. In either of the two scenarios, the result that you generate is actually not going to be a relevant and a true result. So to adjust for that missing data, this method of multiple imputation is employed, meaning thereby that either you have a continuous or a categorical variable. On the basis of that, with these different methods, in just a very simple term, for instance, if you're assessing a particular reading for 5 babies, and you have the data available for 4 of those babies for this particular reading. So for a 5th baby, if you have a missing data, you either use a mean score of that particular reading of these 4 babies, and you use that mean score of 4 readings as the 5th score. So this is just a very simplified way in how I explained, was either you can do by a mean, median, mode method, or you do with these chained equations, which is to fill in for the missing data. Then primary outcomes were expressed in terms of p-values, and all other analysis was reported as point estimates. A post-hoc synthesis was also conducted later after the finishing of the study, updating all relevant evidence to place their results in context with the previous studies, and which again I'll talk about subsequently when I come to that. So this is the flow chart, and so to begin with, they had 1634 fetuses which were enrolled and assigned to either of the two interventions. And if you come to the bottom two boxes here, these are the babies. This is a study cohort which was actually followed up and included in the in the APTS follow-up study, which is the study that we're talking about here. So it was 764 babies assigned in early group and 767 babies assigned in the late group. And here, if you see, is that that in both of the groups, there were actually some babies who did not undergo the treatment as per protocol. And if you see here in the delayed cord clamping group, there was actually a more significant number of these babies, like 202 babies did not receive treatment as per protocol. And finally, only 564 received intervention. So if you compare 710 and 726, which were included in the primary analysis for the early clamping group, this is not so there is no so much difference. However, here in the delayed clamping group, there's quite a significant difference between 709 and 564. Now these babies who did not receive treatment as per protocol actually had a lot of these babies who did not receive delayed cord clamping after 30 seconds, because a lot of these babies we were leaving at clinician's discretion. So these babies may have been assigned to that group, but because of the clinical concern owing to clinical instability, these babies were actually clamped earlier than 60 seconds. Now, why this is important is some of you may think that because of this, actually, if they had done a per protocol analysis instead of an intention to treat analysis, it would have given a more sound result, and the result of the study would have been actually better and more relevant and more true. per se. But why this is actually conducting an intention to treat analysis was better in this scenario. One being that if there are so many babies who did not receive treatment as per protocol, and even after including all of those babies, despite of that, they still got a result which showed us decreased mortality in babies who are in this particular group, meaning thereby that if actually all of these babies had actually received intervention as per protocol, it may have resulted in a more reduction in mortality. And second thing being, this is a pragmatic trial, so meaning thereby that in a real world scenario as well, there will be a lot of these babies who will be, you cannot give an to each of the clinician, there cannot be a hard and fast rule of when to conduct clamping if a baby is clinically unstable. So this study is actually giving a more real world scenario in terms of how the analysis was done. Now coming to the results, so the median time to clamping was 60 seconds in infants assigned to DCC and 5 seconds in infants assigned to immediate clamping. In terms of baseline characteristics, they had matched, both the groups had matched in terms of sex, gestational age, birth weight, presentation at birth, multiple birth status, mode of delivery. However, there is no comment upon the antenatal corticosteroid administration here and other antenatal risk factors as well. Now going to the results. So they showed that in terms of primary outcome, there was a significant reduction in mortality in the delayed cord clamping group. And also in terms of secondary outcome, the incidence of death at 2 years was also low with a statistically significant value. However, for other, in terms of secondary outcome, the other major disabilities, it was not so. And for some of these outcomes like cerebral palsy, visual loss, and deafness, the result could not be estimable, which is why like meaning thereby that the incidence of this particular secondary outcome in either of the two groups was less than equal to 1%. Thereby the relative risk of the reduction between both the groups could not be calculated and commented upon. Then they conducted this subgroup analysis for sex and for gestational age. And in the subgroup analysis, however, in terms of sex, although there's a quite a contradicting result, however, it cannot be you cannot give a conclusive statement on that because the result is not statistically significant. Hence, the subgroup analysis does not particularly give any such relevant outcome. Now coming to post hoc synthesis. So post hoc synthesis, firstly, what it means that in literary terms and in broad terms, it means that that you're conducting a study, and after you've completed the study, so post completion of a study, you have already your results available and ready. Now your study is done, you cannot go back to changing how the study was done. But with those available results, if you want to comment upon a particular outcome, that may be your primary outcome or secondary outcome, or that may be some other outcome that you intend to look upon. So after the completion of the study, if you do any of that, and you may compare it to the previous studies as well, so that becomes a post hoc synthesis. So what they have done here is basically like what you see here for each of these two variables, where A being death and disability and B being death by 18 to 27 months of corrected age. So one thing is that in if you do a meta-analysis, so you define that at this particular time, before this particular time, all the studies that were conducted, you assess the results of all of those studies and you put them forward in a forest plot or in any other way of expressing the result. When this meta-analysis includes your own study as well, and you conduct a meta-analysis including your own study, and you look upon how your study fared, and you compare that with the previous available results, so that becomes a post hoc synthesis. So here what they said, that in terms of death and disability, again there was a clear cut showing that an overall estimate favored the delayed cord clamping group. However, there was only one such study which was conducted prior. In terms of the incidence of death by 18 to 27 months, although the previous two studies had actually touched the line of no effect, making it statistically insignificant, but still, because the sample size was of the study at hand was so much, so giving an overall estimate effect saying that the delayed cord clamping is actually better in reducing for both in terms of fewer death and disability status. So this delayed cord clamping reduced the relative risk of death or major disability at 2 years corrected age by 17% as a statement, and also mortality at 2 years was 8% versus 11% respectively, with a 30% reduction in relative risk. Now here also what I would like to comment upon is that in when they had conducted this similar when they had given this similar statement for the previously conducted study, which was done at 36 weeks post-menstrual age, again a 31% reduction in relative risk was observed. However, if they had said that after adjusting for multiple secondary outcomes, the result was not statistically insignificant, and that is why they had outruled that delayed cord clamping may have reduced the mortality at 36 weeks post-menstrual age. However, they owed that to reduced power of the study. Now here, since the now we're looking at mortality at 2 years, and again now the sizable variation has also increased over 2 years, and the power of the study has actually been retrospectively commented upon, which can be done like to estimate a power of the study. If you go it retrospectively, then that can change per se. So what they concluded upon was that owing to a larger power at this particular interval of time, mortality at 2 years was giving a statistically significant reduction in relative risk. Now, the limitations of the study being non-blinding of staff and parents, heart rate or time to first breath or to regular breathing were not recorded, and also which I have previously also discussed was that 26% of infants in delayed cord clamping group, in those clamping occurred before 60 seconds, reflecting clinical concerns for the infant, thereby a protocol breach. However, 80 to 90% of very preterm infants breathe by 60 seconds with gentle stimulation. So in those also the delayed cord clamping protocol could have been followed where it was not so. So that was why the results of this this particular study, including these preterm infants who did not meet the actual protocol window, may have given a different result. The conclusion being that it has already been consistent with WHO policy, and also meaning thereby the delaying clamping for at least 60 seconds in very preterm infants reduce death or major disability at 2 years. Coming to the future research directives, the principal challenge for future research is how to enroll the number of infants required to find moderate but clinically relevant improvements in mortality. Meaning thereby that if you want to reflect upon now this is a one intervention that is causing such a huge change, like a moderate to high change in terms of the outcome that it is aiming to achieve. So if you want to assess a large change in the outcome by a single intervention, so to comment upon the clinically relevant the clinical relevance of that particular outcome, you have to enroll several thousands babies. So that is why, even though this study in terms of the sample size is sound enough to be to say that 1500 to 1600 infants is actually a sizable sample size, but still to comment upon whether this intervention actually gives a clinically relevant outcome or not, we need to include a lot of babies, and that is why international partnerships and collaboration trials will be required to actually give a statement as a directive. Also, the trials in low middle income countries are warranted for our resource settings, as the data of the high income country could not be extrapolated onto our resource settings. This is the consort abstract checklist. So this article met almost all of the criteria, including the title, the contact details for the author, the trial design was mentioned upon adequately, the methodology was adequately and mentioned upon in the headings. In terms of results, the important adverse events or the side effects of either of the two interventions was, however, not commented upon. Other than that, almost all of the criteria were met. Coming to the CAS checklist for this. So yes, the trial gave a clear-cut focused issue in terms of the hypothesis and methodology was clearly defined. The randomization was proper. All the patients, they had actually reflected in terms of the flowchart also of what happened to the babies who were randomized and who were lost or in whom the follow-up could not be completed. The the treating clinicians and also the patients knew about the blinding, so that could not be done properly. The baseline characteristics for both the groups were similar and were met, and the algorithm and the deviations from treatment algorithm was not commented upon, so that's why cannot tell about whether the groups were treated equally or not. The primary and secondary outcomes were specified clearly. The confidence interval limits were also given and specified. The study population demographic is different, obviously, because the study had the sample size of high income countries predominantly. So that is why, being our study population demographic being different, we cannot extrapolate the findings onto local population. The clinically important outcomes were considered in the study, and the benefits were the harms and costs. Yes, because in terms of the harms and costs, there was could not be particularly commented upon, so that's why the benefits are worth the harms and costs.
Good. Thank you, Dr. Pari. Dr. Sujata, are you there? Any comments? Any thought process?
Yeah, I would like Pari to tell us the difference between subgroup analysis and sensitivity analysis. Just a revision sort of thing, because sometimes there is confusion between these two types of analysis.
Okay, yeah. Pari?
Yes, sir. So, ma'am, so basically secondary analysis of any particular study can be done either in the form of sensitivity analysis or a subgroup analysis. So, subgroup analysis is basically when you subgroup analysis is relatively simple, where if you see your study population and you divide that study population into multiple number of things, like for instance, you divide them in terms of age, in terms of birth weight, in terms of any particular baseline characteristic, and you want to see the outcomes of in terms of those, like here in terms of age, you specifically saw the outcomes, so that is a subgroup analysis. Like for each one of those baseline characteristics, if you do a separate analysis. However, what sensitivity analysis is, that here you either adjust for that particular characteristic or you adjust for some missing data. Like for instance, here if they said that sensitivity analysis was done for 5 of those factors, so just in a very broad term, for instance, if you have a general study where you're seeing the incidence of death in terms of in two population size, and you see that in one there's a particular incidence of smoking, in another there's some different incidence of smoking. Now that, as maybe you can call it a confounding factor, and that has affected the outcome of death. So you exclude and you take that smoking factor out, and after adjusting for that particular characteristic, now you're looking at what is the direct correlation of, let's say, cancer causing death in each of these two groups. Now here in our study, we had these 5 of these baseline characteristics for which sensitivity analysis was conducted. So after adjusting for each of these, like I take out the gestational age criteria as not being a differentiating criteria, and then I do the analysis. So whether or not I get the similar results is the question. So similarly, for that is what sensitivity analysis is conducted for.
Any comments from, I think I could see Dr. Swapna from Hyderabad, Dr. Anita from Mumbai, or Other members, Dr. Leela from Cochin itself. Any points, any comments?
Dr. Suryawanshi, I would like to request, since you are such an expert on hemodynamics, I would request that for the sake of the students, if you could explain a little bit about the hemodynamic effects of delayed cord clamping.
Okay,
How it helps hemodynamically, just in a few lines.
okay. I think I saw the last lecture somebody has done on delayed cord clamping or placental transfusion. I think the last month a nice lecture has been taken. But the most important concept, just to remember that if you allow the ventilation of the lung first, that means aeration of the lung first, then the pulmonary circulation improves. That means by doing the delayed cord clamping, we allow the ventilation. Once we allow the ventilation, naturally the pulmonary circulation improves. Once the pulmonary circulation improves, ultimately the pulmonary venous blood flow improves and the left side, the preload improves. The biggest problem happens in the early cord clamping is there is a hamper of LV preload. By early clamping, you are depriving that preload and ultimately you have a decreased cardiac output, variable systemic and diastolic blood pressures and cerebral pressure. But by this delayed cord clamping, at least 60 seconds, you improve your LV preload. Ultimately, you improve your cardiac output, you improve your coronary circulation, you improve your cerebral circulation, and variations of those heart rates and cardiac output. Hence, we have seen better SVC flow, better cerebral oxygenation, less IVH, less NEC, and less mortality. These are the basic parameters. It's a whole lecture, but I would say this is just one slide you all can remember as the placental transfusion and the hemodynamics. That would be the one which is important for all of us. So allow the baby the placental transfusion in the preterm also, and that is what is important. There is a separate discussion on the cord milking. I will not come here in the cord milking. We all know that we don't do the cord milking in less than 34 weeks or preferably less than 32 weeks, and we allow the delayed cord clamping in those baby, preferably in the preterm babies. Yeah, that's what I would like to say here. So I think the after 1 month we will have another paper from India from Dr. Bhavya about the transitional circulation and the delayed cord clamping, and that how it has improved also. I'll share in the group also, but that's what I would like to tell about hemodynamics. Yeah.
Thank you.
So, yeah. Dr. Nandini or Dr. Swapna, I could see this other members from various states. Any comments, please go ahead on that. Okay, I think looks like this is an important study for all of us, especially that we need to have our own data, which is still missing about the long-term data. We do have a little bit data about delayed cord clamping and immediate effects from the Indian study, but if somebody is planning to do, I think the 2 years data will be good for all of us from Indian study. So one of the centers or collaborative in future can be done, and along with hemodynamics, that will be good for all of us as a future research. I think with this, the meeting timing is also finishing. So probably that's from my side.